Well, hey everyone, and welcome back to Pushing the Limits. Today, I'm super excited. I have Dr. Suzanne Turner with me. Welcome to the show. It's fantastic
Hi,
to have
Lisa,
you.
thanks.
You
Thank
are
you so much.
You are in Atlanta, and we've just been having a big conversation before we started. And I thought, hang on a minute, we're sharing all the gold here. We actually have to get recordings. Dr. Suzanne is an absolutely fabulous doctor. I'm going to read out on the intro your full bio, but can you give us a little bit of a background? Tell us who you are and where you come from and how did you get here?
Sure. So I started out as a regular family doctor, seeing 30 or 40 patients a day, working 7 a.m. to 7 p.m. and prescribing medication for every single person. Whatever the drug rep told me was the thing that needed to be prescribed, that's what I did. And I was really blessed because I had a couple of patients who came to me and said things like, hey, my prostate's bothering me. What do you think about me taking saw palmetto? And because I have just an innate curiosity, I said, that sounds great. Let me do some research. I don't know what that is. So I started doing some research. Then a patient came to me and asked me if I would write for her bioidentical hormone pack or hormone cream. And I said, I don't know what that is. Let me do some research. So I did. And the compounding pharmacy said, hey, it looks like you don't know what you're doing. Can I send you to a conference? And so I went to a conference and it was like the scales fell from my eyes. And all of a sudden I could never go back to what I was doing before. So I started getting hungry and learning as much as I could. And much like you told me in your story with your mom, I just dove right into whatever I could find that would get my patients better, because there was always a percentage of patients that just didn't get better. Their labs were completely normal. Their all the signs were there that they were sick, but they felt fine. I mean, they didn't feel well.
Yep.
So I kept diving into why are they not? I guess I just believed them. And I was curious enough that I said, there's got to be something wrong if you feel this badly. So I started doing as much research as I could. I went back to school and did another fellowship in functional medicine. And then I went on to do advanced training in peptides and endocrinology and tried to, as much as I could, find as many things. Well, at every stage, there was another level of patients who got better. So I added bioidentical hormones. Wow, all these patients got better that I thought had a Prozac deficiency, or I thought they had they had something else. And it turned out, wow, they just were estrogen deficient. If I fix their hormones, they feel so much better. And so then I was a runner, not like you, but I was the 10K runner, and I injured my hip and just could not run anymore. So I said, I've got to continue to, first of all, I'm fairly competitive. And second, I need the activity. So I started doing a Tabata class and loved that Tabata. It was great. Lots of weights and running. So you're doing a little bit of both, not too long. So it wasn't putting too much injury on my hip. But again, I started injuring myself. There were maybe the training wasn't 100%, or maybe I was not listening, or whatever the things were that were going on. And so I went, then COVID happened.
Didn't it?
You didn't ask me about my exercise, but this is the story.
No, this is great.
Then COVID happened. Before that, I'd gone and learned about peptides to try to treat my hip. I used PEG-MGF and IGF-1 to treat my hip injury. But really the answer was a mechanical change. Mm-hmm. So I went to a gym close by that was, all the gyms were closed, of course, but this gym would let you in the back door with the lights out, one person at a time.
Wow. I love it.
It just happened to be a powerlifting gym. And I had some good acquaintances who were powerlifters that I admired. So I started training for power. My intention was just to be active, but as I progressed and continued,
competitive.
I started to get competitive. Yeah.
Yeah, and you are a competitive powerlifter to this day. And I
Yes.
heard you on another podcast talking about powerlifting and what it's taught you from even as a physician, like muscles equals longevity, Yeah. Did that light bulb go off in your brain when you started doing powerlifting? You would have known that to a degree, but it's really, really a big thing, isn't it? Myokines and things like that.
Yes, I think it really hit home when I started learning about peptides. You know, when you begin to delve into what the cell needs and how the cell functions and how the mitochondria work, as I am trying to optimize my ability to be the best power lifter that I can, of course, all this longevity stuff comes out. So like you're talking about myokines and trying to optimize the way that your body functions. What I tell patients is these are chemical messengers that your muscles produce when they're exercising that tell your body to be more youthful. So your DNA will begin to produce more youthful proteins than it would if you were did not have an exercising muscle. So your doctor, I probably back in the day was telling patients, oh, you need to exercise. But now I can actually tell you why you need to exercise. It's not just that you need to exercise, although that is true. I can now say, I can tell you that your body will be younger if you are exercising regularly. Look at your mom, for example.
Yep. Yeah, exactly. And the more we do, the better she is. And with her, it's the weight training that actually brings the most benefit, because when you're older, you start to lose muscle mass. And when you lose muscle mass, this is an endocrine functioning organ that you're losing mass of. And then that your metabolism goes down. That's when you start to get the insulin resistance happening, maybe the middle-age spread. All of those things are related or in part due to the muscle decline. So if we can keep our muscles active and strong, and the myokines, the messengers, and, you know, I really want to dive deep into peptides a little bit with you today as well. And sort of understand that. I heard you say on one of the podcasts that when you're powerlifting, you have to be on your best recovery. Like, you need to recover massively. And as a, ultra endurance athlete in the past, I know that I had to really recover hard, and I often didn't recover enough, and that's when the damage would happen, right? Yes. And you said that your grip strength was one of the things that you noticed. If your grip strength was down that day at the gym, that you weren't 100% recovered. And if you weren't able to lift just that tiny bit more, 1% a week, I think you said, then you weren't really getting the recovery in between. And I was just like, oh, wow. Because grip strength is one of those very simple ways of measuring our aging, isn't it?
Yes.
If we've got a strong grip, then there's lots more sophisticated Horvath clocks and DNA methylation and things like that now. But just for that layperson on the street who doesn't know, if you measure your grip strength, you can buy a grip strength measurer. That's a real indication. And you, as an athlete, of course, you're in tune with your body. You'd know that, my grip's not too good today. I can't lift that huge, great weight off the ground. And your form would be off and things like that. Tell us a little bit, how do you measure when it's time to go hard and when it's not time to go hard?
So I use an Oura ring. I think that's just the simplest way. Hate to advertise for people, but I can definitely recommend the Oura ring. I use that a lot, and I use the heart rate variability that's on there to guide me. I know that when my heart rate variability is down, and I have a fairly low heart rate variability to begin with, I think because I train so hard.
Yeah, me too. I can't get mine up.
And so I think, in running a business and all the things, but I know that when my heart rate variability has gone down, that's a day when I need to rest. So for example, I just came back from a conference. I traveled across the United States, so several time zones, and came back. So today was a rest day. I did not go in this morning, which is unusual for me to not train on Mondays. That's usually let's go back to the gym. But I'm getting ready to go into training mode for competition in August. Mm-hmm. So I know I need to, and this was my last travel before I start really focusing hard on that training. So I took a rest day today, and then I'll hit it hard tomorrow.
And that is the wisdom that you've built, because with me, I used to be like, if I feel shit, go harder, because you must be being a wuss, And now I'm like, no, hang on. I had to travel last week for work too. I had 2 days in a row with only 4 hours sleep, and immediately I got a cold, I was just like, okay, back off for 3 or 4 days of the training, even though my brain's going, but you didn't train for 2 days. You've got to go harder. And you got to really sort of talk that voice down sometimes, that athlete voice, which can be sometimes too, too hard and too strict, and it's actually now you need to actually follow that HRV. I follow mine, and I remember talking to our mutual friend Dr. Betsy Youth, and she was like, yeah, my HRV shit too. I don't know why, I'm doing all the things, and I'm like, so we're in good company, you and I. And it's a battle because, you're running multiple businesses, you go, you're training your backside off and trying to get that HRV up. I'm still in the lower part of the population for that. It's quite disappointing. But
so there was an interesting study that might be interesting to you that came out, I think it's 2018, that's with the Polish rowing team, where they gave them 160 milligrams of the amino acid L-theanine.
Oh, yeah.
During their training coming up to competition, and it prevented them from getting sick. It raised their gamma delta T cells so that they were able to prevent illness. So this was one of the things in my armamentarium against the virus that just was out. Yep. So it's might be helpful for you.
I mean, I've had L-theanine on occasion for for adrenal HPA axis dysfunction and problems like that. I hadn't realized that could help with that. That's a good tip, right? Off to get some theanine.
Yeah, just Google Polish rowing team L-theanine. I bet it'll come up.
Now I want to dive into a little bit into peptides and things, because you are a peptide specialist. You teach on this stuff, and I'm very, very fascinated with peptides, and I've done a couple of interviews in the last couple of weeks with Betsy is one of them, and Ryan Smith I had on the show as well, and Natalie Nidham, and I'm these are hard to get in New Zealand. The reason I'm doing these recordings is not to make everyone jealous that Americans can get all these stuff and we're struggling. It's because I believe, and I'm working on trying to get them down to New Zealand. And I think with the more awareness that I make out there in the space, and then I have quite a few doctors listening to the show, maybe I can pique their interest and they can go and get trained. Tell us, where did you do your training? Dr. Seeds or the A4M or which institute did you do peptide training
Yes.
with?
Back when I trained, it was Dr. Seeds and the A4M. They were together.
Oh, yep.
And so I trained with them. And then Betsy and I started teaching with Bill. And then SSRP split off, but they both have great training programs for peptide care.
Great. So any doctors listening, one of those programs might be good. I want to do the peptide training as well, but oh man, it's pretty intense, isn't it? From even just understanding the sort of basic pathways and stuff. So I'll have to take a deep breath and take a bit of time out to get my head around that one. But tell us a little bit how you use it in your practice and what you've seen. If we, I can list off, 100 different peptides, but maybe what do you see coming into your clinic? Because you're, practicing with this for years now. What would be the most common thing that you use peptides for? We'll start there. Probably a good place.
Probably number one is athletic injury, athletic recovery. That's probably what I see the most. Things like I have a lot of patients who have osteoarthritis, those sort of people who are still active, still playing tennis. They're out there, building muscle, trying to be athletic, and they are having injuries occur either to tendons and ligaments or to the joint itself, and watching the joints deteriorate. One of the things that's most frustrating, I'm sure Betsy said the same thing, was that it's frustrating because by the time I see them, it's often too late. People don't come to you when the injury originally occurs. I just saw a patient earlier today who she had the injury 2 weeks ago. And I said, why didn't you come to me right away? Because let's get on this as quick as we can to prevent a lot of the inflammatory, the immune recruitment that can occur. And then the macrophage activation, and then all the production of the inflammatory cytokines that can occur, these messengers, chemical messengers that will create an ongoing problem If we can start that from the very beginning and nip it in the bud, it's a way better process.
Yeah.
And then for our younger athletes who are currently or continuously competitive, they want to continue to be competitive. And so we want to help them to be able to get back to sport as fast as possible. And there are lots of things we do for them, both actual in the tendon or ligament and systemically, that can be helpful in either treating or preventing injury or illness.
Yeah, brilliant. So things like BPC-157 and ipamorelin, tesamorelin, so the growth hormone secretagogues, I suppose would be in your sort of first line defense for these guys.
And thymosin beta.
Yeah.
And then I'm a big, I love that the modifications of IGF-1 that we can get, that the body naturally makes in response to injury. So the first, in response to the injury, the body will begin to make MGF, mechanical growth factor, not PEG MGF, that's synthetic, but the MGF. And so we want to, as quick as we can, to put some MGF where the injury occurred. And then the body naturally will begin to switch over from making MGF to making a different form, a more healing form of the IGF-1. And so then we want to put IGF-1 on board. So you want to do the MGF first and then IGF-1 after that for an acute injury. Both of these are going to help with more rapid repair. And we know that your body depletes its ability to make any form of growth hormone or IGF-1 as we age. So I see patients who are in their 60s who have their IGF-1 is 75. And we know that a low growth hormone is going to affect the ability of the body to do many things. It's going to increase mortality in general from all causes. So we want to address that low IGF-1. Of course, my goal is always, why do you have a low IGF-1? Let's not just give you growth hormone, which is an option, or growth hormone secretagogues. Let's figure out, why do you personally have a low IGF-1? Are you overtraining? Is your sleep poor? Do you not have enough resistance? Is all of your training ultra marathon? So you're sarcopenic because of what you're doing, your training method, and do you need to cross train a little bit more? I'd love to hear you talk about about your experience with flipping from ultramarathon to CrossFit and what the differences are that you see.
Oh, huge. So from a genetic predisposition, I am not suited to the super long stuff anyway. I create a lot of oxidative stress. I need a lot of antioxidants. One of the programs I'm trained in is pH 360, which is looking at your genetics, but also how you're expressing. And this sort of gives me information about, going shorter, sharper, high intensity workouts. I have a lot of adrenaline, a lot of cortisol, a lot of stress hormones naturally. And of course that breaks down tissue a lot especially when you're older and you're under a lot of pressure. I'm under a lot of pressure with my businesses and mum and so on. And doing the ultra marathons was just another massive stress on the body. And so when I was a competitive athlete doing this for years, I was always holding fluid. My hormones were mucked up, and not just the hormones was a combination of things, genetics and things, and being on the pill for too long, terrible things. But it really, the inflammation was constant. I was exposing my body to way too much oxidative stress and too much inflammation for too long a period. When I switched, when I did genetics and understood that I'd been doing the wrong thing for 25 years, basically, and luckily I was at a time in my life when it was, cool to change something. I'd done the athletic challenges that I wanted to do. That's when I really saw massive changes in my body shape. I lost a lot of extra weight. I wasn't overweight. I was like 4 or 5 kilos just heavier than I should have been. And I was running like no tomorrow. Like, at one point I was running 500K a week, like when I was doing running through New Zealand, and I was just getting fatter. And so that calories in, calories out, and my audience has heard me blare on about that before, but it's not just about that. When I started doing weight training, it was when I shifted that little bit of extra weight. I got really lean, really ripped, and felt a whole lot better and got some hormones. And even though like now I'm, menopausal, and that's another bloody and I'm on hormone replacement therapy. We've just upped the doses because even that wasn't quite enough. So you need to tweak if you're on hormone replacement therapy. You need to monitor and tweak it. But that's been game changer, So I'm a lot happier not doing the ultra marathons. That's not to say that everybody is like me. It's just my genetic makeup as well. But being aware of that is really, really important. I think that anyone who's over 40 should be doing a hell of a lot of weight training.
Amen, sister.
Yeah. Resistance training, muscle building, body weight, whatever you can manage, but you should be doing that.
May I point out how amazing your body is, that even though your genetics were designed otherwise, and even though you had the emotional stressor of your relationship, I listened to a podcast earlier about that, all that in place and all the oxidative stress that you put your body through, it still was able to do the ultra marathons.
Amazing stuff. Yeah.
Wow. Like, what a big hug to yourself. This is so amazing.
Thank you.
That's awesome.
Gorgeous. No, thank you. Yeah. And that's but what I did learn out of that, the negative side on the body and that, but the mental strength that comes from that, the resilience, the relentlessness, the ability to push through, which can have downsides as well, but that's what you learn from ultra marathoning. And that's what I'm a big fan of people doing it for. Yeah. If they're doing it for short periods and they're recovering properly and they're taking into account their genetics and their hormones and things like that, then having that challenge and that ability to push the body to that nth degree when you're young, go for it. That there's reasons to be doing things that aren't always healthy, and I'm sure powerlifting at the top end of the scale like you're doing it isn't always healthy. It is maybe pushing the boundaries, it is, and you're prone to injury, but you're doing it for an athletic goal,
It's interesting, it's a completely different way to think about, there's long rest periods in between sets. We train like bodybuilders. Part of the workout is training like bodybuilders, and the other part of the workout is training specifically sport related. And it's interesting because I am always fearful when I'm under the bar. It's this huge adrenaline, like this exciting adrenaline rush. There's this fear like, oh my gosh, if I drop this, I'm going to break my leg. I'm going to break my back. My knees so many things could go wrong. So you just practice and 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 practice the same thing. I think it's much like training for a marathon or whatever. Yeah. You do the same motion over and over. So your body knows exactly what's supposed to happen.
Yep.
Even with all of that training, 3 years before I did my first competition, I still, the second lift, you get 3 chances to do each of the 3 lifts. And the second lift, I did it completely wrong.
Yeah.
It was amazing. I could even pull it up. It was amazing. I didn't get injured.
Yeah. Yeah. And it's training that subconscious level, isn't it? And really getting that in. Yeah. And then when you've got the competition and the nerves and the anxiety and all that, the brain goes offline a little bit. And that's when things can happen. And kudos to you for taking on such a difficult sport and a dangerous sport at that, really. But how, from a training perspective, how that's going to benefit you as you move forward and get older is going to be huge. Like, I bet your growth factors are doing pretty well. Better than mine probably are. And these are the things that you learn as being an athlete. So there's, being an athlete isn't always healthy. I mean, I love watching the rugby players and things, but I am like, got one hand over my eyes when they hit each other in the head. And I'm like, oh God, another head injury, and head injuries are something that I'm quite passionate about. You need to be fixing it immediately. You need not to be waiting, working on with a Dr. Elizabeth Harris down here, and she wants to get a post-concussion system going so we can get in early, not just sit and wait and rest, but actually get in with the right supplements, the right imaging, so that we know what's going on and not just seeing if you turn out okay, because this is what's leading then. And I'm off down a rabbit hole, but in 10, 20 years time, a lot of those rugby players and stuff or boxers and things are going to be having major issues, dementia, Alzheimer's, and we can see that coming 20 years ahead, and we can do things about it, you know. But it's
especially
trying
if
to
we're talking about, I don't know what you would recommend, but the things that I think have been researched and the most beneficial for things like that. Ideally, I think most of the research is having them on board before the patient gets concussion, if possible. So things like ketone ester.
Yes.
Yes. Things
Plasmalogens.
Yes, things like
Dr.
TB4, thymosin beta 4, and BPC.
Wow.
You know, most of the research with BPC is in rats, but the research shows if you can get that on board before the patient goes, before the rat gets the injury, then we know that the recovery is much better than it would have otherwise been.
Yep.
And things like even mortality is significantly improved.
Wow.
But in the rat study, so they just drop a weight on the rat's head and they had two groups and one got BPC and one didn't. And the ones with the BPC had a way better outcome. Yep. There are more human studies with the thymosins because they are, they've just been around or recognized for a little bit longer. And so there is some human data with the thymosins, but most of the research with them is in animals.
Yep.
And so I can tell you from my own patient experience that that's where we see the most benefit is if I can get people on either human or KE4, whichever people prefer, and then which is the ketone ester supplement, and then have them do a BPC and TB4 cocktail around their training so that we're preventing them from having, so that their brains and their tissue is prepared for the possibility of trauma.
Yeah. And even in the aftermath, I mean, I've got my mom on ketone IQ, and I also have her on BPC, and we cycle on and off thymosin alpha 1, thymosin beta 4, and ipamorelin. And these, like, you know, when you've seen somebody's brain go from completely, you know, really badly, massively damaged to full health again, and then back after the brain tumors to being like a baby again, and then bringing her back to almost full, you know, like if you're sitting having a coffee with mum, you don't know there's anything wrong with her. Only when she's walking, there's a limp, and there's, you know, she leans slightly to the side, and we're constantly working on those sorts of things. But from an intelligence point of view, there's nothing wrong with her, you know. In fact, I've seen her memory start to improve. I've got her on high doses of Glia, and one of the plasmalogens by Dr. Dan Goodenow.
Yes.
Plus I've got her on Stem Regen, which is a stem cell, Dr. Christian Drapeau. And she's in hyperbaric every day. I mean, my mum she gets the best of the best, right? And her brain has come back to the level it is at, and she's independent to the degree. She's not fully independent. She hasn't got a driver's license now. But she can go out for a little walk. She can get herself up. She can go and have a shower. She can, you know, go to the toilet on her own. She can go around the house, make herself a cup of tea. She can, you know, do all those little functional things, go out with her girlfriends for a few hours, you know, all of those things that she can do now. And
Didn't
they
you
make
say she was driving?
We got a driver's license back after the aneurysm. Then they took it off her when she got the brain tumors, and we haven't managed to get it back yet. It's one of her goals is to get back to driving. And but all of those things show a capacity, like to see the brain, the neuroplasticity. We used to think that the brain doesn't develop new neurons. It doesn't change. It doesn't improve. If you've had an injury, if you've got Alzheimer's, you're buggered. It's not true. It's not true. And I've seen it. So a lot of the researchers, I've got like Dr. Bredesen coming on next week, the wonderful
nice.
Alzheimer's specialist. And he's, you know, written a book now about, you know, the end of Alzheimer's and then the first survivors. The first people to actually have had an Alzheimer's diagnosis, then to reverse it and to live full, happy lives again. And this was impossible. This is impossible. And I'm like, Dr. Bredesen, I've seen it. You know, I'm in my N of 1 over here. I've seen that, and I've seen it with other people that I've worked with, that they've had massive slowing down of the decline. Now, the hard thing with Alzheimer's and things is that you have to change radically your lifestyle. You know, you've got to do the exercise, the stuff that we've been talking about, the exercise, the diet, the detoxing, the saunas, the, if you can, hyperbarics, all of those sorts of things that are going to create this baseline so that you can recover, and then you can get some pretty amazing results. You're not going to get everybody, because sometimes it's too far advanced and so on and so forth. But mum's in a pretty bad shape. She was said to be by her specialist, you're below the level of the worst dementia patient, and there is nothing we can do. And this was after a year into her rehab. And this doctor, who shall remain nameless, said this in front of my mum in a panel where we were being interviewed whether we could stay in the physio program. And she had to eat her words, because a few years later she saw mum walking down the walkway. I was having a coffee and I'd sent mum out for her training, and she comes in, it's a miracle, it's a miracle. She's walking, she's like your mum. And I'm like, yeah, you want to know what happened, how I did it? And she was like, no, and walked out. And I was like, oh my God.
You know, I think that's a big shame. I think that I think I mentioned in the beginning, seeing 30 to 40 patients a day.
Yeah, that's insane.
The doctors just don't have the time to be naturally curious. I think medical school burns out of us a lot of curiosity, because it is such a toxic environment. At least when I went through medical school, there's been some changes since I went through, but it was a very toxic environment when I went through, and anyone who asked a question was deemed stupid. So you sort of get the curiosity beat out of you. And I'm just grateful for people like Bill Seeds, like Betsy Earth, people who stirred up curiosity again, for people like Eldred Taylor, who are really terrific leaders who stirred up my curiosity again. And I'm grateful to have been in there around them, and around other people. I could list hundreds of them that have been so helpful and so encouraging for me to be. And so now there's almost not a new thing that comes my way that I don't say, let me go look it up. I don't know. Let's go study. I'm so excited. This is something new I can learn. And maybe I can help 10 more patients by learning this new thing. So it's been really fun.
Yeah, but people are so lucky if they can get into you. And are you actually doing telemedicine? So can people reach out to you, and or do they have to be living in your state to sort of, come under your care?
So I'm officially licensed in Florida, Georgia, Tennessee, and Alabama. I can do telehealth in other places, and people can come see me, but have to physically see me once a year in order to do telehealth. So I have patients who live all over the country, but they come and see me for a one-time visit, and then we do all the rest of their visits telehealth. I even have people who live in Atlanta who don't want to drive through traffic who do that.
Yeah, that's probably a good point. And international as well?
Yes.
Yeah, because like with because this is one of the things, I want to develop a network of doctors that we can reach out to with certain different things, because you need doctors who are specialized in different areas, right? I've got lots of doctors that I try to get people access to, so that they can get these fantastic people that are doing this cutting edge stuff. And even if we run into the problem often with prescribing, but sometimes we can get around those problems, or with getting things over here and stuff. But there's often, where there's a will, there's a way. Often, not always, and sometimes
legally, I think that's right. I think it ends up being the international patients legally have to be I can't prescribe, but I can. It ends up being a consult where hey, let me hear your story, and let's talk about what I think is a great idea for you.
Yeah, and then you can go and try and find a local GP who might agree with that and take that on board. And that's often how it works here. And that works quite well sometimes. And that gives us access to things that we probably wouldn't have otherwise got access to. And you know, I think the message from me for this is just, you know, keep digging and keep banging on the doors, because every person that's doing this is also awakening the curiosity of their doctor to this stuff, maybe. And maybe making them think, oh, maybe I should have a look over here, to the ones that have the capacity. And to your point, there's just, you know, having 30 or 40 clients a day or patients a day, that's just mind-blowing to me. I don't know how the hell you would even remember who walked in the door in the morning to who walked out at night, you know, let alone keep all their records straight and their history straight. You know, like, that's just absolutely, we're asking too much. We're asking too much of people when we asked them to do that. Now, let's dive into a little bit of more into the peptides. And also I would like to cover off, you know, like blood tests we can get, right? Basic blood tests. There is a wealth of information in a basic blood test. Can you give us a little bit of things that if you're looking at someone and all you've got is a blood test and you can't get the fancy peptides, what can you tell from a normal blood test that isn't, when you go to your doctor, you don't get this sort of information?
So it's interesting because this information has always been available to me, but it's only in the last 10 years since I started being more curious and saying, well, what does an alkaline phosphatase actually tell me? It's not just a test that's out there. It actually has a purpose in your body, and it tells us a lot about what might be going on. So from the very simple complete blood count and complete metabolic panel, which almost every doctor orders on almost every patient, at least in the US, then there's so much we can tell from that. There was a research study that came out a few years ago, I think it was 2014, that showed that for every 6 points above 87 that your fasting blood sugar goes, your chance of developing diabetes in the next 10 years goes up by 6%.
Wow. Every point. Wow.
For every point above 87, your chance of developing. We use a different
measuring, but yeah, that would be, so probably above 5 or something like that. Or 5.5 maybe. Yeah.
Sorry, I don't know the conversion.
No.
And so so all the labs measure that as 100 or less is normal. Well, if you're at 100, you're already at 60% increase of diabetes in the next 10 years. Why would I wait until you develop diabetes to begin doing something to help you? That doesn't make sense.
No.
So I am talking to patients from the very first, when I first see them, about their blood sugar being high. And this is already telling me that your body is oxidative stress, your cells are under stress, that the mitochondria aren't functioning optimally, and they're not getting the nutrients, the cells aren't getting the nutrients they need to make everything function well. So that's, no matter what your age, no matter what the circumstances are, 87 or above is where we start to talk about problems. And so I'll start to address, it's an easy segue into talking about what are you eating? And people often don't even know. So I'll just have them do some sort of macros tracker. Just, you know, there's an easy one online called Macros Inc. There's one called Carbon, whatever works for you. I don't have MyFitnessPal, whatever works for you. But I want you to know this is just taking an inventory of what you're doing. I also love the continuous glucose monitors. It's amazing the results that you get from continuous glucose monitors. So that's a simple one to check. And then I'm going to look at what is their albumin level. So albumin is a protein in the blood. It acts like a boxcar. It carries nutrients around everywhere, picks it up at one place, dumps it off at the other place. It just acts like a carrier and protects whatever's in its boxcar while it's traveling through the bloodstream. So as we age, as we have less resistance training, or as we become more sarcopenic, we start to notice that albumin level goes down. When you're sick, for example, when you have COVID, we know that the patients who come in the door with an albumin less than 3.5, those patients are much more likely to have terrible outcomes than the patients who had a higher than 4.5. So my goal for an albumin is to be greater than 4.5.
Yeah, which is here 45. It's just
so I try to track those over time. I'll say, what was it last year? What is it this year? Or what are you doing differently this year that makes things better? I try to see most of my patients every 3 months, and we'll just see what's happening, what's going on. Are are you progressive, or are we headed in the wrong direction?
Yeah.
What can we adjust that's minor that
Yep.
can help you head in the right direction?
Oh.
I need a trainer at the gym for my workouts, just like they need a health, person to guide them what they're doing and to keep them on track. So albumin is probably the second thing. The third thing I look at is an alkaline phosphatase level.
Mhm.
Alkaline phosphatase is unique in that it can indicate all kinds of things, but it is in the body naturally. It rises in response to inflammation. So it's an inflammatory marker. It's specifically often related to intestinal inflammation. And we learned from our naturopathic friends years ago that all disease starts in the gut.
Yep.
So we need to pay attention to things like that. So if I'm seeing a low albumin, a high alkaline phosphatase, I know this patient is not absorbing nutrients from their diet and that there's probably some intestinal inflammation. So I'm going to start to focus on what's happening with their intestines and how do we correct this. So these are just simple tests. Instead of having to order a really expensive, extensive intestinal panel, which would be helpful at some point. I'd rather patients be able to spend their money on the treatments rather than the diagnosis if I can. So I'm going to start with that, going down the inflammatory pathway or the intestinal inflammation pathway. And what can we do to fix this? There's some simple PCR tests that have come out to look at gut microbes. And so I'll maybe throw one of those on to let me know if there's anything unusual happening in their intestines. If they have an overgrowth of something that shouldn't be there. And those are also fairly inexpensive, and they don't have to go through the extensive multiple day testing that's $600 or $800. So those are very simple, easy right there. I also think that we need to pay attention to things like liver enzymes, the AST, ALT, and they give us so much information there too. So we know that for an AST or ALT greater than 25, we're going to start running into problems with, or we're seeing that the patient is having difficulty with either detoxification or, again, some sort of intestinal inflammation. So I'm going to, again, look at what's happening in the intestines. I'm going to treat them whatever way that would mean. I'm going to start with diet. Maybe we'll do an elimination. Maybe we'll look at, are there foods that you need to take out? Are there things we need to add in? Do you not have enough? I love to tell people to please do a vegetable with every meal. Please start with, or it's ordering the meal. So starting with a protein and then going to whatever your vegetable is, and then whatever your carbohydrates are on the end. If you're starting with a protein, we're priming the system for handling the blood sugar more efficiently. So even if you do nothing but reorder your food that you eat, that's a little bit of a problem if you're eating something like lasagna. But if you're having chicken, broccoli, and
salad,
potato,
or eat the potato last, eat the chicken first, and eat the salad in between.
And people, when they're watching their continuous glucose monitor, will see a difference when they make that simple change in their diet. So we'll watch to see if that makes a difference. I'll repeat labs 6 weeks or 3 months, which tends to be, so 6 weeks is kind of that midway between your 3-month check-ins. So I like to do a 3-month midway check-in, and then we repeat. I order a huge panel of labs the first time I see somebody. So there's probably 20, 25 things on my panel when I first look at them, because I want to make sure I have a complete picture. And then we're going to pick and choose as we go things we might need or not need, depending on what their initial panel shows.
What about the thyroid's another pet peeve of mine. We often will get a TSH, maybe if we're lucky, we'll get a T4, some even a T3, but there's hardly anybody who does reverse T3, the antibodies, that full panel, the full thyroid panel. And I can order it. I can get it for my clients. They have to pay it privately, but that would be great if that was sort of standard, so that we can make an assessment of what your entire thyroid pathway is doing, and then where we can intervene. And are you seeing a hell of a lot of thyroid people having issues with thyroid coming through?
Absolutely. Absolutely. And remember, my patients are self-selecting, because if patients are going to primarily use their own insurance, they're going to go to, I'm not sure what the system is in New Zealand, but our patients can either use insurance. I'm a cash only pay practice. We don't deal with any insurance at all. And so patients who come to see me are a selected group. And so I either have the really healthy entrepreneur athlete, or I have the very ill, Lyme disease, mold, illness, chronic fatigue, that kind of patient. So I have this sort of dichotomy.
It's actually similar for me. Yeah. I've got the same sort of situation.
They're going to self-select. So you have to remember there's a bias when I see patients, but I would say probably at least 50% of my patients have some sort of thyroid. We have to remember we live in a toxic world.
Yeah.
And so everything's going to affect the thyroid. Lots of things even in the United States, we use a lot of bromine related fire retardants in our clothing, in our furniture.
Yeah.
And so all of that is going to affect the way, we use fluoride in our toothpaste.
Yep.
That's all going to affect the way that our bodies are able to handle iodine, and it's going to substitute for iodine at the same locations. And now your thyroid is unable to do the iodine exchanges that it needs to do to produce the actual thyroid hormones that we need. So
question on that. So fluoride does that? Fluoride actually will stop the iodine being taken up. Did I understand that correctly?
Yes. So it will substitute in the thyroid hormone. It'll substitute. Mm-hmm.
Oh, wow. Okay. That's great info. Take note of that one, everyone.
So this is one of the reasons why I ask, the dental concerns about using mouthwashes and toothpastes and such that are going to kill off all of the bacteria, and the concerns about the nitric oxide, you being able to actually continue to produce nitric oxide. We need good bacteria in our mouths. If we're killing it off with all of the, that's a whole other story for another podcast. But that's another reason for us to be cautious about using fluoride. I don't recommend it for most of my patients. So that's just by the way, lots of interesting things. And so giving patients iodine is something we can do to help to, if your iodine is greater, you're going to start substituting out your bromine and your fluoride for iodine. And so that's another way we can help these patients out.
Yeah, but you got to also be careful with iodine, don't you? If you've got Hashimoto's or things, or you're pushing too hard on that one pathway, because you can do that too. If you've got Hashimoto's and you take iodine, that can actually exacerbate the problem, can't it?
Yes, and all of this should be done under the supervision of a qualified, experienced functional medicine doctor for sure. Or there are some really good, like you, some really great health coaches that know what they're talking about. But you should
always
do some
work with doctors. Yeah, we always work with doctors. You should definitely
do some research into who you're getting your advice from. And my friend Carl Lenore, if you know Carl, who does podcasts too. Carl always says what does he say? The new pressure, the new what's it called? Evolutionary pressure is who you get your information from.
Yeah, we're going to be self-selecting hopefully for stronger people and evolving into a better. But yeah, there is, some of the stuff that you just said. I know, like if I went to the Dental Association, you'd be getting pushback, massive pushback. I had this discussion with a friend the other day. He was having his kids use baking soda, the toothpaste here that's baking soda based. And he went to the kids went to the dentist, and he ripped shreds out of him for not using a fluoride toothpaste, and luckily my colleague's pretty onto it, and he was just like, yeah, that's fine, thanks very much, see you later. And went home. And but this is a confusing part for the consumer and the person. So if you come across contradictions like that, go and do your own deep dive into that area if it's important to you, so that you can make a fully informed assessment and to trust yourself to do that. There are ways, I did a course with Dr. Youth. We did it together, taught a course in, what to fix first and how not to die, it was called, How Not to Die. And, we were looking at how do you do the research and how do you do those things? And that's a really good course to do so that you can make good assessment of the material that you're getting in. I think that's important for consumers to be thinking about. So thyroid, yeah, is and the thyroid, the hormones, the gut health, these are all intertwined and the HPA axis as well in there.
Yes.
Very complex integrated mechanisms that talk to each other and are affected by each other. And so it's a very difficult, thing to be peeling apart. I love to do Dutch testing and look at the complete hormones and check what the methylation's doing, and look at if they're a candidate to be looking at HRT or not, if they're going through menopause, etc. And all of these things are very much, intertwined. If you're going to be looking at that, I like to look at the thyroid. I like to look at the gut health if I can. And of course, as you said, it's always where do I put the person's resources first? That's always the biggest, hardest thing for me. I've got a number of really, really wealthy clients who can just say, give me the whole gambit and I'll get everything tested. And I'm like a kid in a candy store then, because I've got all the data, right? I can go to town and get it all and make sense of it all. But when I've only got a piece of that puzzle, and that's where you have to be really pretty, clever and intuitive and have experience. And when you don't have that whole sort of picture. And so for me, like doing blood work, I think that if we could get it funded every 3 months for everybody just to get a basic blood test, like the $10, $12, run-of-the-mill blood test for everybody, we would have a much healthier society, because we're just going to be preventative. We can see things happening, before they actually become a problem, and wait until they're actually out of range and then a problem. We can see when they're heading towards the top end of that, blood sugar range, for example. And insulin resistance is a thing that I really look at pretty much with everybody walking through the door. I want to know, how are they? And I look at, questionnaires that look at your blood sugar regulation and how are you looking, as well as your HbA1c and your fasting glucose and your, all of those sorts of things, your insulin levels. And then you can make a picture of where they are on that spectrum, because I can tell you most of us are on that spectrum somewhere of heading towards diabetes. I think if you live long enough, everybody would get it, unless we can be really actively trying to stay metabolically healthy. And that's, I think, one of the at the core of so many diseases is metabolic dysregulation and metabolic issues. And if we can start working on that piece of the puzzle, then the diabetes, the Alzheimer's, the cancers, the heart diseases, all of the things that branch off that, we'll have a less likelihood of that going down that path,
I love the Dutch test. You mentioned it a minute ago, because it's fairly comprehensive, even though it's not. What I mean is, I love that they've added at the end the chymeric quinolinic. Yeah. And they've added the oxidized LDL. That just makes it such a complete test.
Yeah, the what do you call it? The
8-OHTG.
Yeah. So is that really looking at the LDL or just oxidative stress in general, that one? Or is it looking at oxidated LDL?
The 8-OHTG is specifically looking at DNA damage.
Mm-hmm.
The oxidative LDL is looking at oxidative stress.
Right. So that's a different marker. Mm-hmm. Yeah, but isn't it great that they've added that plus the the cortisol awakening response? I really like to understand that as well. My God, that's been difficult to get my head around. I've struggled with that one a little bit, with the cortisol awakening response, but seeing that and seeing a patient's coming through with flat cars, or a car that's going down before it goes up at night, or some of the crazy cortisol awakening responses I've seen lately, I'm like, wow, okay, no wonder you're having trouble sleeping or whatever. So getting that, and that sort of plays into that whole hormone cyclicity. Are you doing the right things at the right time of the day to initiate the right sort of responses, and getting that cortisol response on point, with that nice diurnal curve, a nice rise in the morning and then down throughout the day, and then nice and low at night, so that your melatonin can kick in. And I like to work on people's lifestyle habits, like a sleep regime, just like you would with your 3-year-old. If you've got a kid, that you wouldn't give them a a bunch of ice cream at 9 o'clock at night and then make them run around the house until they're all excited and screaming and then try and pop them into bed. It's not going to end well, right? But we do it all the time.
Yeah,
We're doing that to ourselves. So I am very, very strict when I'm at home and not traveling. I've got a very nice strict regime of, my blue light blocking glasses and my chamomile tea and my yoga and my calming myself down as best I can. I do work too late. That's the only it's the only thing, and that's hard when you've got so much work to do that you can't fit it all in the day. But it's trying to prepare that brain to bring those brain waves down and bring yourself down into that right state to be able to go to sleep. Those things are absolutely crucial.
One of the things that's been really cool for us to do, we just started doing therapeutic stellate infiltrations. So the stellate ganglion, the stellate ganglion is the motherboard for the autonomic nervous system.
Oh.
And it lives right here, just behind your sternocleidomastoid, right in front of your C6 transverse process. And it's easily accessible with a little 1/2-inch needle in most people.
Oh.
So you can infiltrate that area with a little bit of cheap procaine and give the patient they actually should get a Horner response where their face becomes a little bit heavy, their eye becomes a little small. And that means their sympathetic nervous system gets turned down. The parasympathetic gets a chance to take over. Wow. Who of us, since COVID, has given our parasympathetic a chance to take over?
Yeah, no, man, that's a constant battle of mine, trying to get the parasympathetic up. Wow.
And so it's been really fun in the last year and a half that we've been doing this with our patients who have PTSD. And then we've expanded that into patients not just with PTSD, but who have, like you're talking about, HPA axis dysfunction. It's been really, really beneficial and helpful to watch these patients recover because they're getting just a little bit of a break from the massive sympathetic response that all of us get. So that's been super helpful, and it can really help with that cortisol awakening response.
Wow.
A lot of,
never heard of it. That's brand new to me, that one. So this is something you've trained in and you have to inject into the neck?
Yep.
Okay, so you've got to have a doctor.
Yep. And most of the time the pain specialists will do it.
And how often do you have to do this? Like every night or?
So the research with PTSD is once a week for 18 weeks.
So you'd have to go to your doctor, have it done at night time, or like how does
doesn't matter.
Doesn't matter.
Morning. Yep.
We can do it in the morning.
The local anesthesia effects last about, and that's where the Horner response comes in, lasts about 20 minutes, something like that. The parasympathetic dominance can last all day. So it's this amazing calm. People talk about euphoria. They talk about the increased margin that for creativity that they have because their brain is not so busy fighting off. Yeah. It's really been an amazing tool. And I have several patients. I have a woman who runs her husband's medical practice who had some terrible trauma in her childhood. And this has really freed her up to be able to do her job and be the mother and wife that she is also, and is doing really amazingly well. So it's been an exciting new addition to the things that we do here at the office.
Wow, that is just, that's going to be difficult to try to get doctors to be trained in that, I suppose, down here, but wouldn't that be marvelous? Because anything that stimulates that parasympathetic is just so, so crucial. I know I struggle personally with, post-traumatic stress, and I've had 8 years of hell, basically, in my life, losing babies and my dad and my mum going through, just like, the shit that happens to us, and COVID, of course, and all of the drama of that brought. And so to shut your brain up is the hardest thing, and to calm down and not be like, where is the next lion coming at me from?
Yeah.
So that would be amazing. And without taking SSRIs and things, I just not going to entertain those ideas, because I know the downsides of all of that. I've been there, done that actually. That's not the answer, but that sounds really, really exciting. Oh, you've sent me down a new path to investigate.
Yes.
That sounds really, really exciting, because and anything, one of the other things I do in the evening, well, I'm lucky enough to have one, a hyperbaric chamber, right? Because I've got a clinic with a hyperbaric chamber, is I try to do that in the evening if I get a chance, even if it's just a half an hour, because that turns on my parasympathetic nervous system without fail. I sort of get up out of there and I'm like, oh, nice and relaxed. I could go off to bed. And that's, these little things, sauna can do that as well, hot baths, things that can just really help that parasympathetic state. Breath work, of course, cold therapy, another one of my favorite things to do.
There's a lot of devices out there right now that are really helpful for it. I really like the Brain Tap. I like the Apollo Neuro. I don't know if you're familiar with those.
Yeah, Yep, I've heard about it. I haven't had it. Oh, Resimax. I'm interviewing the inventor of a thing called Resimax, which I'm testing out with Mum. Check that one out. Sharik Peck, interviewing him next week. And this is certain vibrations. It's a machine that vibrates at certain frequencies. And I'll probably butcher this, sorry, Sharik. But it has certain algorithms that it plays through, and it can turn on the parasympathetic response. It can really get rid of migraine headaches. I'm using it for Mum to stimulate that right side of the body that's had stroke damage and the connection isn't there. So before I get her to stand up, I will rub this vibrating thing this Resimax device. And that sort of just wakes up that side of the body, so that she is, when she goes to stand, she's not, because if she's been sitting for more than half an hour, that the connection from the brain to the body shuts down. Like for us, we've still got it, but she sort of shuts off. And so her first steps are very stuck, like literally like stuck in the mud. And if I do that first and wake that leg up with this, it sort of activates her. And we've only been using it for a couple of weeks, but it's very, very interesting. But you can also use it. They've used it for, you can put it here and then really stimulate that parasympathetic by putting it under here somewhere. And then you can do it here for headaches and, across the top of the head, different areas that you can use it for different things. So check that one out, Resimax.
And have you ever used, did you ever use stem cells in her?
Stem cell injections or anything? No. I'm using Stem Regen from Christian Drapeau, which I'm had her on for the past month or so. And I'm doing a sort of a loading dose of those. And because it's very hard for us to get stem cell stuff down here. There's hardly anybody that's doing it. And if they're doing it with your own stem cells and so on. And when you're 81, probably not, going to really benefit much. So just the Stem Regen, which I'm a big fan of. That research by Christian is pretty compelling, I think. So we're giving that a go, and I'm using it as well.
It's interesting. There are a couple of companies, American Cell Technologies, I think, and again, I don't know what your access to it is there, but that will have the provider take a adipose tissue specimen, like a liposuction. Yep. And I think they call it lipo harvesting. Yep. And then they will expand those cell colonies and cryo freeze them for you. So she could get 3 or 4 treatments in a year that would potentially be beneficial. I don't know all the details of how you would access it from where you are. Yeah. But it may be something to think about, because there's companies all over that will do that. If you could just find someone who will do the fat harvesting, the company will take it and
they proliferate it. They make it, they grow it and then put it back in. Yeah. And I think there is one up north that might do that. I'll have a look into it. I just thought with 81-year-old stem cells might not get much of a, and you're putting back into the body, like damaged senescent stem cells, because there's that argument too.
So you know, a lot of the protocols include doing some sort of pre-treatment with MAH, ozone, you know, ozone therapy, with senolytics, rapamycin, 5-10,
on those,
FOXO4, something like that ahead of time, and then pre-treating with ozone therapy, and then doing stem cell harvesting. So you've gotten rid of a lot of the senescent cells.
Gotcha.
And then you're giving them, you know, for her, because of her history of cancer, I don't know what their restrictions would be, whether they would allow her to do it. Those are all, you know, you'd have to ask the company. They have different recommendations, but those are options. Those are all options. And you know, if you use your own stem cells, they're way better than using somebody else's stem cells, just because your body knows what to do with them.
They're endogenous to you. And this is you know, the easy way, and with you know, like stem cell mobilizers, like what Christian's got in his stem regen, and he spent, I don't know, 25 years or something studying what plants around the world, or what compounds around the world help the body mobilize stem cells. So and he's done all the, you know, a lot of clinical trials with these to show that the stem cell production out of the bone marrow is increased. And of course, when stem cells are higher in the body, then you're going to get repair processes happening much better. And that's one of the reasons why we don't repair well as we get older, because we've lost so much of our stem cells running around in the blood. They're not being, so these plant molecules, things like AFA from Klamath Lake, like that blue-green algae, and aloe macroplata, and fucus something or otherish, it dissolves the solvent that hold the adhesive, I should say, it dissolves the adhesive molecules that are holding the stem cells in the bone marrow, and actually gets rid of those, and so they can be released. And then if you combine that with hyperbaric, that actually proliferates the stem cells and just sort of crowds them out of the bone marrow. So you've got a sort of a double whammy going on, you know. So that's the easy access for people who don't have access to stem cell treatments. I mean, I think it's worth trying. So yeah, we're experimenting with that at the moment. But all of these things are just so exciting, like getting more stem cells in your body and doing, you know, and then back to the peptides, because we didn't really finish the peptide conversation. The peptides are so, there's just so many. I mean, there's 7,000 odd peptides. And then you've got the bioregulators and the peptides, right? And what's your take on bioregulators and Dr. Khavinson, or Professor Khavinson's work for 40 odd years, you know, who started off with the KGB producing stuff for their military. But anytime I hear military are using something, I always double down on my research on that area, because I know that the military, whether it was in Russia or it's the American military or whatever, if like with ketones, you know, like when they're studying something, they usually got a big budget, and they've usually got not the amount of restrictions that we have in the normal society. So they are usually at the cutting edge of things. So I'm always sort of doubling down if the military is doing something. But bioregulators are, Professor Khavinson is probably the major player in the space, and now it's becoming more available. And the cool thing with the bioregulators is a lot of them are oral or sprays, which makes it more accessible for more people. So, but I'm not 100% on them yet, you know, like because most of the work's come out of Dr. Khavinson's lab, you know, there's not what's your take?
I think you're right on. What's exciting is, are you involved with Dr. Bill Lawrence's American study?
I know about Dr. Lawrence. I'm hoping to get him on the show, but I think that might be a stretch. We'll hope, because that would be great. He's Tell us a little bit more.
He's a good fella. He's right here in Atlanta.
Well, put in a good word for me, would you? I'd love to get him on the show.
Yeah, so he's repeating the work of Khavinson here in the United States. I think the most interesting research that Khavinson has is on the thymus gland and the pineal gland peptides, and giving those to patients for 3 years, and then following the patient for multiple years after that. So what they found, the Russian study found, is that significantly lower numbers of patients were ill and had died who had taken the peptide bioregulators for 3 years. So Bill Lawrence is the American version who is trying to replicate the work of Dr. Khavinson under his tutelage. And he is, or in conjunction with Dr. Khavinson, and is trying to make that happen. So he's in the middle of that.
Wow.
I happen to be one of his clients.
Oh, wow.
And so my telomere length went really low compared to where I was last year, just being on peptide bioregulators in the middle of a particularly stressful time. My telomere length went down, but because of having had COVID twice, my chronological age actually got a little bit worse. So this is really curious to see what's going to, so we've made some adjustments to see if we can get rid of spike protein. We've added some bioregulators that are specifically related to that, one called Nemerex. That is a spray. That has some interesting research, limited but interesting research on, I like the word compelling that you used, on helping to remove spike protein. So that's what we're hoping to do for me. I did not ever get a vaccine, but I did have COVID twice. So
same. Yeah, I didn't get vaccine. I got COVID once, and I'm seeing a lot of people with long COVID and vaccine damage as well, unfortunately. And sometimes it's a bit of a double whammy when you've had both.
Yeah.
And so you actually saw yourself go backwards in the first part of the study because of the stress that you were under in this COVID and so on and so forth. And now you're halfway through that 3-year cycle, or whereabouts are you at the moment? You're so lucky to be in that.
So
oh man.
I did my second test in January. So I'll have another one next January. We'll see where things are. And it's just a 3-year study. And then he's going to follow me for the next 15 years. And we'll see what happens. You know, the Russian study, they just called people up 15 years later and said, is he or she still alive? And significantly higher numbers of the treated patients were still alive.
And then he treated a lot in that second time too, didn't he? Like people that were now in their 70s and so on, didn't they continue with the peptides at that point? No, they didn't. Just the 3 years. Wow. But was it injection, or I think it was injection, wasn't it? Rather than the oral and sprays that they used in the original cohort.
The Gazprom study was done with orals. And that's the huge 13,000 people in
Siberia
that work for the gas company.
Wow. And that was, in the very stressful living conditions, I should imagine. And back then in Siberia, wouldn't have been the easiest places to live, I shouldn't imagine. And so those people had, they died less, they lived better, they were healthier, and that was just having these bioregulator peptides for 3 years. And so that's interesting that Dr. Bill Lawrence is in the middle of that, and that's going to be really exciting. And I think meanwhile, if you've got the money and the resources and you want to try that, the very good safety profile.
Yes.
So
what's also interesting is I would consider SS31 and GHKCU. I would consider both of those peptide bioregulators because they are 4 or less amino acids. And so we know that they have significant effect. GHKCU affects 800 something genes, up and down regulates a bazillion genes. So we know that we're getting a more youthful expression of your DNA if you're taking GHKCU on a periodic basis. And I think the recommendation is, once a quarter to do a round of GHKCU. Same idea with Epidolon, to do once a quarter to do a round of Epidolon. And then the other peptide bioregulator that I think is interesting and so effectual is SS31. This is one of our mitochondrial peptides. I think it is, it's had amazing results with my patients who can afford it. It's hard to find. If you can find it, it's expensive. But I think it is one of the most impactful peptides that we have available to us. And so I have a patient who has pulmonary fibrosis that's related to having had COVID twice.
Wow.
And she came to us on oxygen. Of course, we did a lot of things. We did ozone therapy. We did not inhaled. We did oral.
Yeah.
IV, major
IV.
oral hemolytic.
Yep.
And then we did regular peptides like thymosin beta. We also did, but we did SS31, and her energy came back. She was off of oxygen. She was walking.
Wow.
So she's 4 or 5 miles a day. She was doing really, really well.
Amazing. And that's for
Yeah.
something that you can't really fix, apparently. You
Right.
know? So
Yeah.
that's amazing. And would BPC-157 be in the mix there as well, or for things like that?
Yes.
And
So
is BPC not also a bioregulator? Because it's also
it's not, because it's 15 amino. So the official
15.
definition of bioregulators is
2 to
4
4
or less.
Yeah,
Mhm.
2 to 4. Yeah. Okay. I thought BPC was for some reason, as in a smaller number of peptides than that. But is it, so it's what, 13 or 14?
It's 15.
15 string of peptides. But you can take it orally. That's what threw me off, was that the BPC-157 you can take oral and it does
Yes.
have an effect.
You're right.
So how does that happen when it's such a big-ish peptide?
How is it able to tolerate the stomach? It's because of the sequence of amino acids itself that are resistant to the acid environment. It's naturally made in the stomach. So or
true.
at least the longer
Gastric
peptide,
juices.
B157 is the fragment of the original. And so the one that's made naturally in the stomach is a longer version of that, but it is resistant to the acidic environment of the stomach because of its amino acid sequence and its conformation. Right.
No, that because I've used both the oral and the injectables, and we had a situation with a gastrointestinal bleed, and so the oral was important, and I put KPV in the mix as well, under Dr. Betsy's guidance. And
I also like treating both sides. So if they have an intestinal problem, I like giving it systemic and oral, because then you're treating from both directions.
Yeah. And I think when you give it systemically, it could end up in the cartilage or the joint or somewhere else, and not, preferably in that case, I needed it for the gut healing and the gut lining. So that's why we put it in orally as well as an injectable as well. And just going on to some of the other, your favorite peptides or bioregulators from the thymus perspective, the thyroid perspective, what's your take on the bioregulators there, like Thyrogen, I think it's called, and the bioregulators in the thyroid space? Have you used those?
Always going to say the first things we should do is treat with the pineal gland peptide and the thymus gland peptide. So always we should be treating with those two, and then everything else we do for patients with any of the bioregulators should be added to that regimen. And so
a Pidolon, it would be a Pidolon and Thyrogen first,
yes,
and then
or
whatever, and then the blood vessel regulators like Ventfort. And
I'm such a fan of Cardilax because everything is made of everything: heart, lungs, kidney, liver. All of it needs an extracellular matrix. And so I'm always going to throw that one on. I'm always going to throw on the Vesigen to try to get their blood vessels. So those are my kind of number 1, 2, 3, 4 for everyone. And then I'll throw the extra ones on. So if she was on Taxarest oral, the patient I just mentioned with the pulmonary fibrosis, she was on Taxarest. How much does the Taxarest affect her versus everything else? Because we gave her everything. So I have no idea which was the most contributing factor. She ended up having, I want to say she ended up having almost a Herxheimer-like reaction to the thymosin alpha. So we started going down a path of looking at whether she had a mold exposure or something else in her home that may have made her predisposed to the problem to begin with. I had a question for you. Did you ever use in your mom Dihexa or Cerebrolysin?
So yes, Cerebrolysin, but I could only get the 1 ml little vials out of Austria. So I couldn't get what we really needed was the, infusions of the stuff. and really high dosages. So I think once again, I was throwing a shitload at her at the time when I was doing the Cerebrolysin, and I've done 2 rounds of Cerebrolysin, and I definitely think it helped. I was like, when she got cancer, I was like, oh, do we put Cerebrolysin in? Is that safe when she's got an active brain cancer, like in the brain? And, I conferred with Dr. Youth on that, and we put Cerebrolysin back in the mix, but I haven't tried Dihexa yet. And I've been looking at, have you seen, was it Jordan Harding, I think is his name, the researcher who studied the Parkinson's rats? Have you seen that video? There's a video. He's talking about Dihexa. He's given one rat Parkinson's, however they give rats Parkinson's, I don't know, but they do. And then one without Parkinson's, and then one with Parkinson's treated with Dihexa. And they're hanging on a pull-up bar, these rats. So he sticks them on a bar and they're holding it. Now, the Parkinson's rat falls off very, very quickly, obviously, because it's got Parkinson's. The normal rat falls off about 10, 12 seconds later. The rat with Parkinson's treated with Dihexa hangs around there for a good, good minute or something, like 3 times as long as the healthy rat, don't quote me exactly, but it was like a lot longer. So, and when I was talking to Ryan Smith last week on Dihexa, because I was like, I wrote to Betsy and said, Dihexa, should we do Dihexa? And she's like, we should doing it all. She said, or Ryan said that there is like something like 10,000 times the amount of BDNF produced when you have Dihexa. And I'm like, what? Like, yes. BDNF is the gold that we're trying to get a little bit of when we have saunas, or we're hoping we get a bit when we do hyperbaric, but really 10,000 times the amount, is that safe? And that to me, like, sounds very, so I haven't yet put Dihexa in the mix. I need to have another appointment with Betsy and just see whether that's an option. And what's your experience?
Here's what I would say about Dihexa. I have patients with MS who've had great results. Mm-hmm. I have a patient who has vascular dementia who's had great results. We've really kept her very, very, very stable with her symptoms. It's been amazing to watch. So we were able to reverse her initial decline, and then she's stayed at that same level since we reversed her initial decline. And so we cycle her on and off. And one of the things I always encourage these patients to do is to find something they love doing that they want to learn. So my perfect example is salsa dancing, because it uses the upper part of your body differently than the lower part. It uses left and right. It requires you to remember steps. Wow. So there's a learning process that goes on. I think powerlifting is a very similar, if you were going to do weight training or something. So anything that you're willing to learn that requires you to hold on to information, but I don't want you to start Dihexa until you start doing something that challenges your brain to do that neuroplasticity. So whatever that is, I have a patient who picked up learning guitar, and he was able to memorize the whole songs and things where he wasn't able to before remember, 2 or 3. So it's, I think there's been some really dramatic changes. It works. One of the ways that it works is by decreasing the inflammatory response on the brain, because it is angiotensin 4 agonist. The angiotensin 2 receptor is this inflammatory producing receptor. And if we can get that turned down in the heart, in the liver, in the brain, we know that we can increase the anti-inflammatory response of the immune system, the microglia in the brain. So they go from that penny, oh my gosh, the sky is falling, to the janitor, put things away, take the trash out. And we can get a good response in that direction so it's not just the fact from Dihexa, it's not just the fact that Dihexa increases BDNF, although that's a wonderful effect that it has. It's anti-inflammatory and changing the phenotype of the immune system in the brain, helping the oligodendrocytes begin to lay down myelin again in patients with MS. So it's very exciting to see what it can do and what it should be able to do. Again, most of the research is in animals. So when I have these conversations with patients, I go, I don't have any human studies to tell you what it's going to do. I can't make any promises. But this is what it's done in animals. There is nothing out there for you. So
Yeah.
I think it's worth a try. I mean,
Yeah.
you tell me if you think it's worth a try, but I think it's worth a try.
Yeah. And this is the thing when you're up against it and it's your last, things like, this is when you should be able to initiate these sorts of things. And then there's C-Lank and C-Max. Have you had any experience with those two?
Yes. So probably the most benefit I see for those is in patients who have either a history of addiction or who have the fairly high HPA axis drive, that we can get that turned down. There's a lot of GABA that's produced there. I think the other place where this would be really beneficial is in our ALS patients who have that glutamate, that high glutamate around the synapse that's causing a lot of inflammation. I think we get some benefit in those patients too.
Wow.
From using C-Max and C-Lank. And I think especially if we can use these things to help get patients off of their benzodiazepines, et cetera, that's where I think they also can come in to be really helpful.
Isn't it amazing that we've got so many of these exciting new things for things that are really like traditionally got you're on a path to destruction and doom, like multiple sclerosis and ALS. I work with an ALS patient and or client, and you're given there's nothing, there's some drugs that they can do to maybe help with a little bit of this or a little bit of that, but actually there's a lot more out there, and getting them access to the right information was really, really key for them. I didn't even put any of the peptides in because, well, I can't. But just having that information, I'm going to pass that on because they may be able to now go over to America and maybe find you or Betsy or someone that may be able to help. Yeah. Because I think when people like that are just got no other options and they're facing a really horrible decline, why not try, Dihexa, C-Lank, C-Max, Cerebrolysin, a combination of those sorts of things to try to rehabilitate the brain and get them back. I know I certainly would.
If someone has ALS, I am highly, highly going to recommend them see a dear friend of mine named Amy Jaramillo. She's in Miami. She has the largest non-university based ALS clinic in the world.
Oh, I think I've heard of her. Yes.
She's amazing. Yes. And she has 5 reversals of ALS.
Yes, I
2
have.
of which have been recognized by Duke University. 3 are awaiting recognition by Duke University. So these are genuine reversals of ALS under her care. So, ALS is an incurable disease, but
Richard Bedlack is another one to put on your radar there. Dr. Richard Bedlack, he's also studied the people who didn't decline and what did they do. Yeah, he's studied for years. And one of the things that he put in was theracumin, and there was a whole list, I can't remember off the top of my head, but there was like a whole list of things that all of these people had done, and he's studying that. So yeah, Dr. Richard Bedlack was his name, another very, very interesting out-of-the-box thinker that I came across when I was researching for that client. So yeah, there's lots of things out there that are just cutting edge, and it's coming all the time. And even when you study for a couple of hours a day, you're still not going to keep up with it all, eh? It's just not enough hours in a day. I sometimes get, God, I wish I just could do more, be brainier so I can remember it all. That would be just great. But
you've got Dihexa.
Use some Dihexa, and maybe I'll become like the limitless guy in that movie. What was it?
Or Lucy.
Yeah. Look, hey, I want to be a little bit respectful of your time, Dr. Suzanne. It's been absolutely fantastic to have you. Is there anything that we didn't cover that is really like your hot topic you want to talk about? Anything that we've touched on some pretty exciting things, but anything that you wanted to add?
I think that we've covered most things. I can't say enough about the growth hormone secretagogues. I think, most peptide doctors are familiar with using those. The FDA approved one is tesamorelin. I think it works amazing. I love tesamorelin. I'm going to cycle that on and off with other things. I think that is foundational for any program that I'm going to start for. I'm not going to say all patients because everyone's different, but it really is foundational for most of my patients is being on some sort of growth hormone secretagogue. Even your mom with active cancer, we think that probably ipamorelin is a safe one to use. That's
the one that Betsy's put her on, ipamorelin. Yeah. So we haven't gone with the other ones, but that one is the one that we've chosen. Or she's chosen.
Again, there's no research behind that. There's no, I don't have a human study that shows it's safe to use in active cancer, but because of the way it works, because of its ability to help cells get out of that glycolysis, that Warburg effect, we think that's why it'll be beneficial in helping patients to, and so that's a complicated another story for another day, but don't forget that's sort of baseline level of foundational for most programs that we'll do.
And getting yourself more metabolically flexible is really good in every which way. I did want to touch just briefly on hormone replacement therapy, like ladies going through menopause or men going through andropause, if you want to call it that. Are you a fan of people finding out and under the care of someone who's qualified, doing Dutch testing and all of that sort of stuff? What are the benefits you see of hormone replacement? Because we're still fighting against the Women's Health Initiative over here.
Absolutely. And we are here in the US too. And I still have patients who come in and say, my best friend is afraid of using hormones because of the risk of breast cancer. And it doesn't matter what profit in her own home is without honor. So
exactly. Yeah. That's what I keep saying. I like that saying. That's really good.
But I think that there's so much evidence of benefit. The two big studies that just came out with subcutaneous testosterone in prevention of breast cancer. I think those are really powerful studies that were done by Dr. Glazer and Dr. Donovitz about using subcutaneous testosterone. I'm a huge fan. That's my favorite route of administration is subcutaneous testosterone. I use a fairly low dose of subcutaneous testosterone relative to those studies, but I think it's pretty interesting. Actually, mine is more in correlation with Dr. Glazer's dosing. But it's
for yourself, or you're just in general now. Yeah, for yourself.
Both. Yeah. Not while I'm competing, but when I'm off season. Yes.
Yeah. I'm taking. I can only get access to testosterone cream, so I take it that route. I don't know if it's as effective as the subcutaneous probably would be, but that's what I've got access to. And because I want to maintain my muscle mass, and I tend to be catabolic because of the stress levels that I run under and the stress and the amount of things that I do and the training that I put myself through. So, I want to maintain a little bit of muscle or a lot of muscle actually. And so testosterone's in the mix, and then, DHEA as well. Do you put DHEA in the mix in your regime?
Yes. In fact, the testosterone we use has a DHEA, the injectable has DHEA in it.
Okay. And because if if you're someone like me with hormone, sort of hypothalamus, pituitary, adrenal gland dysfunction, and you're flatlining on your cortisol awakening response, DHEA, that's going to go along for the ride, isn't it? When your cortisol's in the
so you just have to be careful, because if your cortisol is already in the tank, my experience has been if I put DHEA on board in someone who already has a low cortisol, I might make their cortisol worse. Whereas if their cortisol is high, I'm probably going to make it better by adding DHEA. So that's just sort of my experience. If I see that their DHEA is low, but their cortisol is high, I'm going to replace DHEA. If I see that their DHEA is low, but their cortisol is low, I'm going to address what do we need to do? How do we get your cortisol up so that then we can add the DHEA in? It's obviously they're deficient, but I think sometimes the body is wise and is doing things on purpose So what's happening with their teeth? What's happening with their sinuses? What's happening with their intestines that may be causing, it's not always just an emotional stressor. I don't mean just, but it's not always an emotional or environmental stressor. It may be an internal stressor there. We forget about things like root canals that are problematic in so many people. I can't tell you how many patients I've said, will you just go see your dentist and ask them to do a CT scan instead of an x-ray? And lo and behold, they have an abscess in their tooth that they didn't really feel. Maybe they had a little bit of sensitivity, but nothing's crazy. And their x-rays were normal, but they were systemically unwell.
Shit, I've got quite a few root canals.
Yeah. So you can actually treat that with injectable Procaine and ozone if you want to do that. That's a simple way to do it. I don't know if you have a doctor who would do that for you. If you know a holistic dentist, they might be able to do that for you.
Good luck trying to find that. Probably, but I will have a look. Yeah, because I probably do need to. I've done extensive work, dental work, because of the ultra marathons for decades. I remember coming back from the Himalayas. I did a really 222k race in the extreme altitude, and 3 teeth fell out in a week. So pretty horrendous state, and they look great now. I've had a lot of work on them, but I do wonder sometimes about the root canals. What's going on there, and you don't know, right, if you don't have access to something like a CT scan. And
most dentists have plain x-ray, so you're not going to get what you need from just a plain film. Sometimes will show up, but not always.
Very interesting. Right, we've covered a lot. I think we've really gone around the block a couple of times. I'd love to have you back on. I'd love to stay in contact. And where can people find out, reach out to you, talk to you or your team? Are you on any socials? I don't imagine you have time for social media, but
I'm on Instagram. So you can look for me on Instagram. It's at Dr. S. Turner, Dr. Turner.
Yep.
And then on Facebook, but I don't do too much of my Facebook. I have a book coming out in October called Counterclockwise. So that's exciting. We'll
reach out before the book comes, and we'll get you back on to talk about that.
Good. I'm excited. It's really fun. It's sort of setting down a cairn, saying this is a fun thing that I've done, and so I'm excited about that book. And
where do you have time to do all of that? I have no idea. Overachiever much. Absolutely amazing. Okay, so and your main practice, Vines Medical, is that right?
Vine Medical. Yep. Vine is in Grapevine.
Yep.
And we are vinemedical.com.
Excellent. Okay, vinemedical.com. We'll have all the links there, and we'll wait with bated breath for that book to come out. That will be definitely on my bedside table when it does. And thank you so much for your time today. It's been absolutely amazing. Thank you, Dr. Suzanne.
Thank you. So nice to meet you. Really a pleasure.